Hi, this is part of the OCT tutorial series. I'm going to use polarization sensitive OCT or PS-OCT to demonstrate to go through hypothesis-driven OCT research, which I feel strongly is lacking in it, along with double-blind clinical trials. We'll only touch on the theoretical aspects of polarization sensitive OCT or the applications. It's me again. And I just want to point out I've been doing MI research since 1984. In around 93, was in search of a way to image vulnerable plaque. Came across OCT, which was not capable of imaging plaque or non-transparent tissue. Worked on that for most of the rest of my life, including now, and worked on it for cardiology as well as other fields. And I want to point out that at times I've had 5 R01s, and a lot of people, I'm not trying to brag, I want to point out I was trained by basic sciences, both my postdoc and my PhD, including working with Nobel laureates. And you have to do hypothesis driven research with specific aims. It's critical in the funding process, and a lot of people who want to just do pure engineering struggle to try to get funding or don't get funding. And I just want to point out how important that is. So OCT, this isn't a shocker, has been heavily on the engineering side, and the basic side is small. We represent a large part of it, and honestly, we may have introduced it into the patient too early. Too many basic studies, well done basic studies, needed to be performed. And I want to emphasize a clinician is not a clinical trials scientist. And so we will do small clinical trials. These are not double blind trials here, but I'm primarily a basic scientist, though also a clinician. But what I'm not is a clinical trials expert. I'm a buffoon when it comes to clinical trials. You need somebody like with an MPH or a Greg Stone, for example, or a Michael Gibson. And hypothesis driven research is critical in NIH funding. And this, I believe, this plays a lot of role in why it's taken, OCT has been so stagnant since 2000. Um, so you you don't go from one in vitro study to patients saying, this is what now I can now interpret what I see on the OCT image. Um, it requires a lot more than that. And it's even worse when you don't even have the one in vitro study. But when we look at inflammatory cells or microvessels or layers which are people are attributing to healing, have these been validated? Have the hypothesis been um, tested effectively? And we'll just discuss this, but OCT is in desperate need of hypothesis driven research, both basic and clinical prospective trials. In the end, medical research comes down to morbidity and mortality. And basic studies get you closer there, but if you're not demonstrating morbidity or mortality, then or headed in that direction, then why do it? We're going to focus on one approach, mostly single detector. It's technically called single channel, and I'll briefly discuss the difference, but it's not that critical. One detector versus two detectors, and I'll explain why. And so most tissue of the body, when you image with OCT, the back reflection is not sensitive to the polarization state of the incident light. In tissue with highly organized structure like collagen, then it is sensitive to the polarization state of the incident light. So healthy cartilage or sturdy intimal caps, which have highly organized collagen, we're gonna demonstrate they're birefringent, and we use polarization sensitive OCT rather than straight OCT, which measures polarization sensitivity or birefringence. We'll come back to this image. I just want to look in the lower left. This is done in vivo in a human uh, joint patient undergoing knee replacement. The bottom left is normal cartilage. It's but highly birefringent. So you've got tons of bands. This linear band pattern on the left of the image, lower left image, that's highly birefringent tissue, and I'll explain that. And some tissue isn't as birefringent. You just have in artery walls, you don't have as much collagen as you do in cartilage or in a tendon, and so you rotate the polarization state. So without going this into detail, the upper right is picroceras stained. The red arrow shows in the picroceras a lot of collagen type 1, and the green arrow small amount. And if we look at the two A and B images, the red arrow area, as we rotate the polarization, the image changes, but in the green arrow area, it doesn't change almost at all. And I'm going to go into this in more detail. And this was part of the images from the paper, the trichromes on the bottom. And the reason I looked at in our study, we just didn't see in fibroatheromas thick and thin a lot of inflammatory cells. So it may be critical for, it is critical for atherosclerosis development. I question how critical it is for ACS. These are some structures that are birefringent, not going into detail. How do we generate a hypothesis? Well, first we see something. So on the top in this paper, in the study, we're looking at cartilage. The top is the OCT image, and we saw bands, and the bands moved when we changed the polarization state, which we'll go into how in a little bit. But from this, we can generate a hypothesis. It may be right, it may be wrong, and we actually generated two. The hypothesis is the moving banding pattern was due to birefringence from organized collagen. And the second hypothesis is the loss of this banding pattern can be used to diagnose early OA, early before cartilage thinning as the collagen breaks down, or weak intimal caps. So what do we need to do to test this hypothesis? A lot. And if we just look at the first line, you need to match on a micron scale the histology with the OCT images. That's critical. And then the way you decalcify is tricky because you have to save the soft tissue, but decalcify the calcified tissue. And then we're going to use a special stain called picroceras, which identifies organized collagen. Whether we're going to use single versus dual detector PS-OCT, do collagen and type 1 versus 3 have different imaging properties? What are the effects of fiber angle? And if you add collagenase, does it change the imaging? Does the medium change the imaging? And this is going to be important when we look at issues of plaque. People look saying OCT sees plaque healing. So was it based on our results based on one paper? No, it was based on a bunch of papers, some of which were pretty large. And so these are the in vitro papers. We've also had 4 in vivo papers. The 4th one's been presented but isn't published yet. But these are prospective studies. They're small studies. They're feasibility studies. They're not double-blind clinical trials, and they're not databases or registries where we're looking retrospectively back at the data. Okay. Chapter 8 in my textbook covers PS-OCT. Also, the 15-page paper, experimental paper on the left, covers the topic extensively, and I would suggest downloading this paper if you're interested in PS-OCT or hypothesis-driven research. I'm limited on what data I can present for this paper because it's not open access, but among the areas it covers is the effect of medium on collagen backscattering, imaging of collagen 1 versus 3, if you have mixtures of them, collagen concentration, and collagenase treatment, the effect on imaging. And so now let's just go on to single versus dual detector OCT. So the channel part is just has to do with an engineering term, and we're just going to use one detector versus two detectors for the sake of this talk. So with single detector PS-OCT, it's a qualitative measurement. We're looking at banding, or for instance, like we saw in that one first image, and it's qualitative just like a chest x-ray is. It measures the relative values, just like you measure the relative value in a chest x-ray of the heart versus the lung. I've heard people in the engineering community call it primitive because the engineering in it is relatively simple, which I equate with not likely to be associated with a lot of errors. Dual detector goes for the absolute value. It's going to measure the actual polarization state. It actually measures the polarization state at the detector. That doesn't necessarily mean that's the polarization state in the tissue. But some people will refer to this as elegant. But you use two detectors that allows you, if you understand that polarized light is composed of, let's say, an X and Y component in or out of phase. The two detectors allow you to measure each one of those, the X component, for instance, and the Y component for the sake of this talk. Okay, these are example schematics of single versus dual detector OCT systems, but there are a lot of variations on this, and these are just simple examples. So single detector OCT is fortunately simple and shown on the left. So what we do is we add polarization paddles to the system, which alter the polarization state. It can be viewed of the incident light. And as we saw, if the tissue is highly birefringent, it's banding patterns, and we don't even have to bother moving those paddles. In the artery, where you have far less collagen, you do have to rotate the polarization state. In contrast, dual detector is far more complicated. If you look at the red arrow, it's pointing to a beam splitter that splits, let's say, into the X and Y component that'll allow you to tell the exact polarization state at the detector. And my problem is, at the detector does not mean within the tissue, and we're going to go into that in a little bit later in the talk. And there's a lot of ways to introduce errors here, and simple is good. So actually, dual detector reflectometry preceded our work, dual channel. So that was done in 1992. It was not B scans. It was the equivalent of an ultrasound or an echo A scan. And this is early work, and he, Swanson, Fujimoto, and a second paper, again using dual channel by DeBoer, Milner, and Nelson, who are all very talented. But physicians use categorical data for a lot of reasons. If you practice medicine, you understand why. We don't use densitometry points in a chest x-ray. We look at the image and we see things with our eyes. So categorical data like banding is useful, and the orthopedic surgeons love it when we do it in vivo in the operating room. Now here, let's just take a tiger is charging at us. Okay, the tiger is 200 yards away. Now, what would we prefer having? A pair of binoculars or a Doppler gun? A Doppler gun is going to give us the velocity that the tiger is moving at, away or toward us or away from us. The binoculars, we're going to just get a relative idea coming or going. There's too many ways that the Doppler gun can have errors in it. You can miss the target. You can be getting the reading off something else. If I had my life was bet on if that tiger was running at me or not, I would pick the binoculars, and that's my logic with single detector OCT. So one area where you're going to get errors is when the catheter bends. And I'm not going to go through the physics why that occurs. This is a drawing of it first. So with the top is single detector. When the catheter bends, you just get movement of the bands. But with dual detector, you get a change in the actual values. So the value at the detector does not necessarily reflect the value that's at the tissue from the bending. Okay, and this is just a drawing of it. I'm going to be more specific in a minute. And so, again, like the one on the top. So we did a study, it's cited here. We passed the catheter through the casing that the catheter, a coronary catheter came in to maintain a fixed radius of curvature. And we tested single versus dual. And so first, when we look at single detector, which is the one we like, when it was bent versus straight, there was a slight tendency for a difference, 50 versus 54. It wasn't statistically different. Now, if we looked at dual detector, and you can look at the paper how we did it, there was a 30% change in the value. So, and that was highly statistically significant, 0.0001. So I'm a single detector person. Can single detector diagnose pathology? Testing the hypothesis. All right, first, matching isn't as critical when you have a tendon, but we start off with a tendon because it's got about the most dense, the bicep tendon or the Achilles tendon, collagen you're going to find. And you get this thick banding pattern. And when you shift the polarization, the bands shift, but it's highly banding. And the picroceres lights up, showing us that we have organized collagen. So we can shift the banding pattern or the polarization state by putting in polarization paddles. And you see a polarization controller on the schematic on the left. And this just shows the paddles. And these particular paddles come from a paper where they're motorized. I'll bring it up later. It does have its use, but you can do it manually too. So now, if we look at, this is cartilage, and if we look at the lower right, the picroceres, it's bright. It's loaded with organized collagen. And if we look in the 3 OCT images as we rotate the polarization, it is not as loaded with collagen as that tendon. We don't have a bunch of bands, but the band is smoothly moving as we change the polarization state. Now, okay, we have, here is where matching on a micron scale is critical, because dropout areas of collagen, if you're 500 microns off, you're not matching. So if we look at the lower right, there are areas that aren't lighting up in the image. You see dropout areas. And if we go to the OCT images on the left, it's not a smooth band. We've lost some of the areas aren't behaving as nicely. And H&E is in the upper right-hand corner, and that's only relevant in the next one. So this one was great. So if we look at the picroceres, it's devoid for the most part of collagen, in spite of the fact the thickness is pretty close to being normal. And if we look at the OCT images, no bands, no changes with polarization, which is exactly what we would expect with loss of organized collagen. And if we look at the H&E, to be fair, the H&E, it probably would look normal by MRI, but by H&E, there's an awful lot of chondrocytes on this image, and it's not staining totally appropriately by H&E. So by H&E, it doesn't look quite right. Now let's get back to these coronary arteries. And so again, look at the picroceres. This is a different artery, but so the red arrow lights up and it's got collagen type 1 in it. The green arrow in the picrosericin C doesn't have a lot of collagen in it. So we rotate our paddles, simple single channel PS-OCT, and the red arrow changes dramatically. The green arrow changes very little. But this is this is not proving the hypothesis yet. You need blinded readers, do all your great statistics. We had 3-point scales and 2-point scales that showed statistically we predicted correspondence between blinded readers that was statistically significant. And we can get more complicated. We're not going to get more complicated for this talk, but this is us rotating it at a constant rate. And it's like echo. You have to get used to looking at it like regional wall motion abnormalities. But you see various changes within the artery wall as you rotate it. So you're getting it, you can get this information very quickly if you're used to doing it. So, okay, we've made a pretty strong case so far in testing our hypothesis. We need to test it in vivo. So how can we test it in vivo? So in patients undergoing total knee replacement, we image, then they're getting total knee replacement. So if we mark the cartilage, we have the cartilage is being removed. We get send it for histopathology after we've imaged and it's been removed from the patient. And so we were able to correlate in this study PS-OCT in vivo with histopathology. And this was even more strongly shown in rotator cuff tear. So we we did OCT imaging after a rotator cuff tear of the tendon being used to reattach. So we imaged right on the line where the surgeon cut off tissue, and what was left was supposed to be completely normal. So we would have the end that we took away corresponded to the attachment site. And so the surgeons felt 100% visually all the tendons that were left were healthy. And actually, only 50% of the tendons had significant organized collagen. But the correlation was highly statistically significant. And so this is another in vivo correlation between collagen and PS-OCT imaging. So we can diagnose pathology in cartilage, tendon, and coronary arteries. Could we do something else? Let's try the collagenase experiment. And these are challenging because collagenase isn't a small particle. So we did do it with acid and it worked, but that doesn't tell you, that's not specific to collagen. So on the left, this is unpublished data. It's not from that paper, but it can be found in that paper I referenced earlier. But these were not used in any paper. On the left, before adding collagenase, on the right, 24 hours later in a meniscus, you see that the banding pattern, a lot of it has been lost. But this is meniscus. It's a type of cartilage. Technically, it's classified as fibrocartilage, but it's very well organized fibrocartilage. We lost a lot of the banding, but it's hard, takes a long time to get that enzyme in, so you didn't lose all of it. Media composition, critical. Does it affect the imaging of collagen? So we used something called Helistat, which is a collagen type I sponge. It's just a block of collagen type I, and we immersed it in saline, ethanol, and oil. And this has become important, like for instance in lipid plaques, does being in a lipid region change a water-based region? So the back reflection intensity was much higher for the same amount of collagen in saline than it was in oil. And we go to these studies that are looking at layering. So in theory, you can have the same amount of collagen type I in two different layers. One, though, is more lipid. one is more water-based, and the back reflection intensity is going to be different. So for me, I'm not going to measure back reflection intensity for healing. We looked at the birefringence. So the bottom is we put a reflector underneath the sample, and the reflection off the mirror stayed the same. The reflection from within the sample, so for saline, was much higher than it was for oil. The birefringence stayed the same, or was not statistically different. It may have varied slightly, but it still showed that it was birefringent. So PS-OCT is a better way of looking for plaques that have collagen in them than just looking at back reflection intensity of layers. Can we detect mixtures? Now we're getting into areas that need more research, but yes. So this is meniscus, and it's got both type 1 and type 3 collagen in it. It's got multiple types of collagen. And so the upper left is the OCT image. The right is the histology. I'm sorry, it's in black and white. I can't find the color version. The A scan is in the bottom left. But what we did is a Fourier transform. It's done a lot with OCT. It's the spectrum, and we got two different peaks for what we believe is collagen type 1 versus collagen type 3, but more testing is needed. But we came to some of these conclusions by modeling, and we did extensive amount of computer modeling in this paper from the Journal of the Optical Society of America, and so we modeled birefringence, if the bundles were big, if they were small, if they were in medium, all kinds of different parameters, and then did the Fourier transfers of those to get an idea of how we can differentiate when you have situations, for instance, all these different scenarios that the collagen can be in. So some extras. You need a standard. So we need something to test the system every day to make sure the system isn't varying. And the system varies less, obviously, with single channel than dual channel, but we needed to come up with a standard to check our measurements, because that's good science. And we tried helostat sponges and various things. We went through a lot of conventional things, and then got the idea of using dinosaur teeth, which worked out incredibly well. And so the one on the left we have, it's a horse dinosaur tooth, a prehistoric horse. It was the best. But the one on the right is a megalodon tooth, which you can buy on eBay or a variety of places. You mark a spot on it, and it's been around forever. So, and it's been birefringent forever. So it's not going to change from day to day. And we did demonstrate that. And so if we look on the top, the megalodon tooth, the prehistoric horse, and the tendon were all highly birefringent. And then we took the tendon and exposed it to acid, and it lost the birefringence. And meniscus is less birefringent. It's fibrocartilage, remember, than a tendon. So if we look on the bottom, the A in the Picroceras is the tendon. We didn't actually do histology on dinosaur teeth. C is after treating it with acid, and E, that's meniscus. In certain sections of the meniscus, you can see the organization is not equivalent to A, which is why it has less of a birefringence. Now, we actually can determine the polarization state by knowing the positions of the paddles, and we have that information if we really needed it, just like you could do densitometry if you felt like it on a chest x-ray. And we can plot the data. We set up original baseline sphere of three-dimensional polarization spates, a Poincare sphere, and we can provide absolute values with this system if we choose to, but then we're just going to be more likely to introduce error. And if we're showing it's effective in diagnostics in vivo, particularly in orthopedics, we've shown it, then why would we go to a more complex system? So clinical utility, musculoskeletal. And I've shown you those other studies, but this is an in vivo. This is our attempt at a double-blind clinical trial. I mean, it's an exploratory double-blind clinical trial. This is just the time zero data. You can find it on PubMed, but we compared, these are patients that were normal by MRI, normal by arthroscopy. They were getting meniscal surgery, and then half were abnormal by PS-OCT, and half were normal by PS-OCT. At 2.8 years, if you went back and did an MRI in a small number of patients, we've presented this data as posters. We haven't published it yet. The ones with abnormal PS-OCT all developed at least partial thickness defects. The ones with normal PS-OCT at time zero developed no osteoarthritis. And so we need to publish this data. And I want to emphasize it's a small study. It was only designed as a feasibility study to design a probe. So again, we weren't actually going after those results with the study. So I wouldn't consider this by any stretch of the imagination a strong clinical trial. We weren't trying to do a clinical trial. We were trying to just develop the optimal probe for joints. Cardiovascular applications. So you want to know if a plaque is weak, and if it's lacking collagen, it's weak and it's not going to have great healing capability. And the other type of healing is if you, data by the Stone group, I think it was part of the Prospect study, or it may have been a spin-off from the Prospect study, showed a lot of thin cap fibroatheromas become thick cap fibroatheromas, which we feel we know why. And so plaque healing, we resorted to hypothesis-driven research, and we did not use except for one thing, the database retrospective studies. So in JAMA Cardiology in 2019, the critical point is that we said, I believe we coined the phrase, acute coronary syndromes may require a double hit of both rupture and impaired healing, which is analogous to oncology, where they looked at oncogenes for years and finally found that 50% of human cancers have a mutation in a tumor suppressor gene, which would be the equivalent of healing. And we went on to say that this was due to long necrotic cores where angiogenic vessels did not get to the area because of the long cores, and you lost cellularity, the synthetic smooth muscles and the synthetic and the endothelial cells needed to contain a clot after a rupture, or they're needed to make a thin cap fibroatheroma, thick cap fibroatheroma. And we originally pointed at these long cores being the source of ACS rather than TCFAs. Only 18% progress to ACS, so they're not the vulnerable plaque. And we thought it was long cores. And that was based on this study, which I'm not going to go into here. Long longitudinal cores. We didn't originally have the idea until that circulation paper I just showed you. Now, this is the study that's used to validate, quote, healing diagnosis by OCT. And it has 18 autopsy subjects. It's not using polarization sensitive OCT. It's using backscattering. And this is, for all the clinical trials, and they did use picosericin. I have to give them credit for that. It's a very difficult stain. It is explosive. But if you look at the paper, as far as I know, all the other studies that are, quote, assessing healing are did not do in vitro studies to validate. So it's based, as far as I can tell from the paper, on 18 patients, which is a very small number compared to the number of studies that were done in vivo with layering. But there is one point in the paper where they said 28 patients, and it seems like the 10 patients were removed, or that may have been a typo in the paper. So in our circulation paper, we didn't mention one of these healing papers when we described the mechanism we used. It ACS is a combination of rupture erosion and failed healing. We used the OCT, we used more IVUS studies than OCT studies. Unfortunately, it's sad for me being somebody who really is an OCT person. But in these studies that are listed here, the one thing, these were retrospective, or at least some of them are retrospective studies of databases that are looking at layering based on that previous study. The first two are, and two of the other OCT studies didn't even have anything to do with healing. What we were looking for is core length, and that's what we got out of the non-healing studies and the healing studies, was core length. In the papers, ACS was associated with long cores, and then through everything from the Berger papers, look at an angiogenesis in 84, papers on how it takes days to weeks to form a clot, and smooth muscle cells getting in a clot, stabilize it. Those are the reasons where we came with that double hit theory, and that angiogenesis is critical to it. Also, the fact that patients on angiogenesis inhibitors get more clots, both arterial and venous. It would be more ideal to be using PS-OCT for this if you're really looking at collagen. But we generated our hypothesis again, not using this layering data, but using other sources that are outlined in the circulation paper. And I'd like to thank the NIH for all our funding through the years, like over 15 years of funding, and your patience for listening.